Hester explained at the beginning about the kind of the scoping exercise and about the sort of the survey. And one of the things that came up was about oncological emergencies. And I had to think about what that perhaps meant for brain metastases, because I think when you hear about oncological emergencies, you think of two things, don't you? You think of spinal cord compression and neutropenic sepsis. I'm not talking about either of those. So, what I'm going to talk about is some of the things, I suppose, sort of acute change in brain metastases patients. So that's what I'm going to talk about for the next few minutes. I'm going to talk about three things. I'm going to talk about acute neurological deterioration after treatment, because we've heard, and again, hopefully you'll find that there are recurring themes which are running through the day, and one of those is about treatment effects, about radiation necrosis, about changes in the brain due to the treatment. We're going to talk about venous thromboembolic disease. Again, Liz has mentioned that, about how people are much more prone to that, because again, there's often lots of angsting about whether or not you can anticoagulate these people. And I'm going to touch a little bit about epilepsy. Liz is going to talk much more fully about epilepsy this afternoon, but I'm going to touch just a little bit about epilepsy in the emergency situation and what constitutes an emergency and what doesn't. So, I'm just going to just a couple of stories, a couple of case histories. So this is one of my patients, fit 51-year-old lady who we treated radically for rectal cancer about 4 years ago in 2012. If you have rectal cancer treated, you go into a colorectal follow-up program where you're screened for initially with scans, but then with CEA tumour marker blood tests out to 5 years. And she had a rising CEA tumour marker. On that basis, she had a body scan. On that basis, she was found to have small volume, 3 tiny little areas in the lung and a secondary in the adrenal. And again, it ties in. We talked about people being managed more aggressively because she was being worked up for surgery to those sites. The cardiothoracic surgeons will take out 3 lung metastases. The urologists will take out an adrenal metastasis. And so she was being worked up for radical resections of those. But she was in a cardiothoracic consultation, and she just mentioned in passing, really, that she had a bit of sort of minor headache, bit of shooting pain in her head, nothing dramatic. She mentioned it in passing. But because the cardiothoracic surgeon was working her up for pretty major lung surgery, he didn't want to take any chances, and he not unreasonably did a brain scan, which showed 2 metastases. So she'd one at the front there, just behind the right orbit, and one further back here in the left parietal region. But she'd absolutely no other symptoms at all, nothing. Her headaches had settled by the time she came for her brain scan, and her performance status was 100, KP was 100, performance WHO PS 0. She was continuing to work, continuing to do all of her normal activities. But because she had these 2 lesions, and because that one is coming a bit close to speech area, if you try to operate on that region of the brain, you can get speech deficits. And also because there's 2, and the surgeons wouldn't operate on 2 areas, we decided to give her stereotactic radiosurgery. And that's her SRS treatment delivery. So you can see again, Dr. Whitfield's shown you this, nicely conformed around the 2 abnormal areas. Because she was eligible for stereotactic radiosurgery. And again, you know this now. She had an excellent performance status. She had a life expectancy of more than 6 months. She'd controlled or controllable systemic disease because she'd never had any chemotherapy. She'd had adjuvant chemotherapy, but she'd never had any chemotherapy for metastatic disease. She got loads of options to treat the metastatic disease, which was small volume. And so she had stereotactic radiosurgery under our care in April of this year. She tolerated the stereotactic radiosurgery without any difficulty at all, flew through it. We give them a little bit of dexamethasone just around the time of the SRS delivery. So we give them, and again, we tailor it a little bit, but roughly we give them 12 milligrams a day for 3 days, 8 a day for 3 days, 4 a day for 3 days, 2 a day for 3 days, and stop. So we give them a little sort of 9-day pulse just to sort of get them over those acute few days of the SRS treatment. But other than that sort of little pulse, she hadn't had any steroids at all. But then, and she was great, she was working, she was super. But then really quite suddenly, 3 weeks after her SRS, she developed really sudden onset, severe, continual headache with nausea and vomiting, worse on leaning forward, and that can be one of the classic features of raised intracranial pressure. Happened on a Saturday night, as these things do, so she phoned the Christie hotline actually, and she was commenced on dexamethasone, which I think was absolutely the right thing to do because she had symptoms which were suggestive of raised intracranial pressure. It wasn't a medical emergency. She wasn't dropping her Glasgow coma scale. She didn't necessarily need to go to casualty. She was started on dexamethasone, and that was very reasonable. But what she had then was, she was then re-scanned, and what the scans showed was that the lesion was actually quite a lot bigger with lots more edema around it. So what you can see is that there was the two areas. So this one in particular looks much bigger. You know, if you just measure the absolute size of that, it's much bigger. But what you can also see is it looks kind of hollowed out. So, and similarly with this one again, if you just measure the absolute dimension, it's definitely bigger, and you can see the amount of swelling around it. But we took these back to the Neuro-Oncology MDT meeting with a specialist neuroradiology, and they said, no, we really think this is just treatment effect. And so the message was to just manage her with symptomatic care and with steroids. So just as Liz has described, management, if someone has necrosis like that, we tend to give them, they tend to need to get a decent dose into the system, and that's usually for a couple of weeks. But again, as Liz has just beautifully outlined, the dose really depends on how much edema there is, patient tolerance, prior steroid use, you've got to tailor it. But a sort of a decent boost, bearing in mind that we keep saying this is all individualised. In this situation where they've had another brain scan and we know that this appears to be radiation change in the brain related to treatment, the message is just to sit tight and to try and reassure, to provide support, and if they are developing deficits either due to the steroids like proximal myopathy or because, like the chap I presented earlier with the metastasis in his motor strip, if he'd had those changes in his brain, he would unquestionably have had more weakness down his left arm and leg, and so to refer for physio, you know, early on. And then rescan, just repeat the imaging in about 8 to 12 weeks. She is now getting very much better. So she had this nasty sort of acute event, but she's now back down on 2 milligrams of dexamethasone. But she, when we took her down from 2 down to 1.5, all her symptoms came back. So she's gone back up to 2 milligrams. And so the message is just to sit tight. So that kind of thing is, it's not an emergency in that, you know, she probably didn't need to go to casualty. The ones where you worry about is if they really are dropping their Glasgow coma scale, if they're getting progressive neurological weakness. But she was start on steroids and bounced back very quickly. You do get a very rapid response with steroids. This is similar but more difficult. So this is, again, similar story. So this is a 69-year-old lady who had a renal cell cancer resected in 2010. She had small volume lung metastases, just little dots in her lung, diagnosed in 2012, but her disease was behaving very indolently. It wasn't growing very rapidly at all, and so the renal team were just watching her, monitoring her. But she developed some weakness of her left arm and leg in May of last year, and she had an MR brain scan which showed 2 small metastases. Now, I realised when I was writing the talk, actually, I've only shown one on there, but the other one, you'll have to take my word for it, was very close by. It was just kind of below it, just below and beyond it. And we treated her, again, because she had controlled or controllable systemic disease. She'd never had any systemic treatment for her renal cell cancer. She had low volume disease. She definitely had a life expectancy of more than 6 months. She had a good performance status. She ticked all the boxes. She met the criteria for SRS. And so she had a single fraction of SRS in June of last year. And she initially, again, was pretty well. But on her first post-treatment scan, 3 months after her SRS, again, the lesion looked a bit larger. Now, again, I was talking to you earlier about why we do the contrast scans and how the contrast scan is what's really important to show us the lesion. And this is the contrast scan. You can see the lesion, again, looks bigger in terms of its absolute size. It looks like it's taking up contrast very avidly. But on the pre-contrast scan, this is now lighting up white. And what that means is that there's some blood in it. So she's had a little bleed into the metastasis. She did have increasing left-sided weakness, again, as you might expect, because there was more edema, and it was probably, the edema was probably filtering upwards into her motor strip. When we're uncertain what's going on in the brain, just based on the MR scan, we do what we call perfusion imaging, and that's done, you can do either CT perfusion or MR perfusion. And what that does is it essentially takes, it's like time-lapse photography of the contrast going in. And that gives neuroradiologists who are clever enough to interpret this an idea of whether what we're looking at is necrosis, so treatment effect, or whether it's disease progression. And they felt that it was treatment effect, that it wasn't disease. And so again, same story as the previous lady. Don't panic, keep calm and carry on, steroids and support. And again, for her, because she was developing increasing left-sided weakness, this is what Sarah and Julie are going to talk about this afternoon, it's really important to maintain function. It's not just rehabilitation about trying to restore function. It's about if someone is going downhill, it's about intervening, first of all, to keep them safe, so they're not falls risk. Second of all, if they do need a walking stick or whatever that they're using, they've got the right size of a stick and they're using it in the right way. But thirdly, to try and maintain function and not let that deterioration get out of hand, to try and intervene as early as possible. But you can see that over time, her disease is actually, her scan appearances have got worse, and mirroring that, she has also got worse. Those were the scans we looked at before. Again, in September, it looked bigger again. But by March of this year, again, it was developing this real fluffiness. You just get a feeling that something solid here is falling apart and breaking down here. But the tricky part for me, and I find this situation very difficult, is that she remains very steroid dependent. She's got this continual weakness of her arm and leg, again, which she's been discussed repeatedly at the MDT. She did loads of scans. As far as we can tell, this is all still treatment effect. So again, the message is just keep going. But this is difficult because in some ways it's slightly academic. It almost doesn't matter to her whether this is disease progression or treatment effect. I suppose in terms of her overall survival, the fact that it's treatment effect, you know, is better in terms of long-term prognosis. But in terms of her long-term, in terms of her day-to-day disability, she's probably got the same problems that she would have if this actually was disease growing. And I think sometimes this is a very difficult psychological situation for patients because you get into this, well, maybe the treatment's harmed me, and, maybe if I hadn't had the treatment, I wouldn't be like this. But I think certainly with her, she obviously had the left-sided weakness at the outset. That's what she presented with. And without treatment, that would unquestionably have got worse. But again, it is this. So this is, again, this is true survivorship. This is living with and beyond cancer. This is living with the effects of cancer treatment. And so for this lady, it's steroid dependency with all of the things that Liz has just outlined to us that goes with that. And, very significant supportive care needs in terms of rehabilitation, practical help, but also the psychology of it all. So, in summary, treatment-induced swelling and oedema is common. It can come on soon after SRS, or actually it can come on many months later, often 6 to 9 months. And just again, like Charlotte was saying, we think you perhaps nip off a blood vessel. The imaging inevitably, we know when we consent these people that we're not going to get rid of this disease completely. The SRS isn't curative, it doesn't get rid of the metastasis. And so inevitably when you rescan, there is a mixture of disease and treatment effect. But again, just follow-up imaging, supportive care, keep going. In most cases, you manage with steroids, supportive care and surveillance. It tends to be an urgent rather than emergency, but when it's an emergency is when somebody is really deteriorating very quickly, where they're dropping their Glasgow Coma Scale, where they've really got rapidly progressive neurology. That is the point where you probably want to be sending them to casualty, not necessarily if they've just got some headaches and a bit of left side, a bit of weakness or something, that it's very reasonable for you to do a trial of steroids in the community. The SRS team remain on the end of the phone, so the SRS radiographers who deliver the treatment up at Salford, patients have their contact numbers, they're available for advice, or the treating consultant, either the SRS consultant or the systemic disease consultant. But as we've just said, they may have significant psychological and rehab needs, because I think this is a terrible emotional roller coaster for people, because they're sort of lurching from one scan to the next. So moving on to venous thromboembolic disease, PEs and DVTs. So PEs and DVTs are very common in brain tumour patients, in primary brain tumour patients, and also in patients with brain metastases, because basically they've got a full house of risk factors. They've got systemic malignancy, which puts them at increased risk. They may be on chemotherapy or may have been on chemotherapy. They may have reduced mobility. They may have weight gain due to the steroids. And in terms of treating, first of all, it's important to have an index of suspicion. So if someone is more breathless, take that seriously rather than just sort of writing it off, because there is every chance that could be a PE. Similarly, if they've got a swollen leg, take it seriously. That could very well be a DVT rather than just a bit of swollen ankles or cellulitis or whatever. When we talk about if someone's been diagnosed with a DVT or a pulmonary embolism, we need to weigh up the pros and cons. Again, it's a theme running through today, isn't it? Weighing up the pros and cons of everything. Because we've got to weigh up the risks of intracranial bleeding into the metastasis with the benefits. Because obviously if we don't treat a DVT, first of all, it's uncomfortable, it's painful, it's nasty, it gets worse. Second of all, it risks spreading into pulmonary embolism, and that can be fatal. If it's a pulmonary embolism, people are unpleasantly breathless and so on, and that can be fatal. And in general, so we've got to individualise this, but in general, the risks, the benefits of treating, I don't know if I put my seesaw the right way around actually now I look at that. What it's meant to say is, it is widely perceived that anticoagulation is contraindicated, and again, a lot of junior doctors are a bit fixated with this. They've got a brain tumour, we've got to stop their anticoagulation. Not the right thing. So it's perceived that, you know, the risks of intracranial bleeding are so high that you mustn't anticoagulate these people, and it's not the case. I would suggest to you that the risks of leaving clots untreated are considerably higher than the risks of causing intracranial bleeding. The balance isn't in favour of anticoagulation if you're looking at anticoagulating brain mets patients for something like atrial fibrillation. So lots of people are on anticoagulants for atrial fibrillation to reduce their long-term risk of having a stroke. Well, they've got brain metastases, they haven't got an endless life expectancy. In those cases, it probably does flip the other way, where the risks, where the benefits probably aren't, you know, probably are less than the risks. But certainly for clots, for established clots, you know, we should be anticoagulating these people. In general, some general points about that. Melanoma metastases are the ones which are most likely to bleed, renal, followed by renal cell, but melanoma way out front, much more likely than lung or breast or anything else. Hemorrhage into a lesion isn't necessarily symptomatic, and it's also not necessarily an emergency. So the other lady I showed you had that bit of bleeding into the treated area. The other thing you can see, as well as seeing hemorrhage into the metastasis itself, you can see a subdural hematoma. Well, again, that's not necessarily an emergency. You know, lots of people walk around with subdurals that they don't even know about. Worst case scenario is, again, somebody who's medically unstable, dropping their Glasgow coma scale. That is a neurosurgical emergency. That needs, you know, referred to casualty and then to the neurosurgeons. But that scenario is pretty obvious. Now, what we do use is we do use low molecular weight heparin at normal therapeutic doses. So just standard therapeutic dose of whichever low molecular weight heparin is locally used. We would not warfarinize them. So that's a key message. So we can anticoagulate, but we wouldn't warfarinize. And I think the reason, again, there is that although we're talking about the fact that risk of bleeding, that the benefits of treating DVTs and Ps is undoubtedly outweighs the risks, equally, if you're warfarinized and you wind up with an INR of 9 or something, your risk of bleeding into your metastasis certainly is higher. So we would use low molecular weight heparin, and also because if you do need to stop it, you just omit the dose and it's gone, rather than warfarin, which obviously can get out of control and can take a while to get out of the system. These novel anticoagulant agents, their role's yet to be defined. I'm not quite sure. I'm still using low molecular weight heparin, and I'm not quite sure where rivaroxaban and things like this sit in this story. But certainly at the moment, low molecular weight heparin would be the recommendation. Just briefly about epilepsy, because as I say, Liz is going to talk much more about this in the afternoon. Really around the question, when is a fit an emergency? Because they're not all. Seizures are a very common presenting complaint. If it's a first fit in somebody with no previously known abnormality in the brain, then you want a 999 ambulance, you want casualty, you want a brain scan. If it's a first fit, even in someone who's already known to have brain metastases, I would say you still probably want an emergency assessment, even if they've got brain metastases but they've never had fits before. Or if it's a fit in someone who is known to have seizures but it's lasting more than 5 minutes, or it seems more severe than usual. Why? Because if we leave fits untreated, they can crescendo, they can turn into status epilepticus, and that, if it continues, can cause serious deterioration and can cause irreversible brain damage. So that's why we need to intervene. But the vast majority of patients with tumour-induced epilepsy achieve seizure control with appropriate antiepileptics. And in patients with known seizures, care needs to focus on empowering people to cope at home, not necessarily dialing 999 every time they have a fit. And so things around that are education, reducing anxiety. Hospital admission ambulance, as we said, isn't needed every time. But equally, if people are very worried, and it's very scary if your husband or your wife is having a fit, even if they call 999, it may be that a paramedic crew is sent, and by the time the paramedics get there, the patient may have come round, they may be fine, and what the paramedics do, well, they just check them over, give them a bit of reassurance, and actually not take them to casualty, or they may take them to casualty and then they're sent home again. But it's about making people understand that they don't need 999 every time, just if, you know, things are much more worrying. Just again, very, very briefly, because lunch is waiting for us, but just management of seizures in the emergency setting, first aid, ensuring safety, someone's not going to fall or hit their head or whatever. Management of auras, if somebody has an aura, so if they've got the type of fits where they get warning that they think they're going to have a fit, clobazam is a very useful tablet, which we're just going to give to people. They can keep it in their wallet or keep it in their handbag. If they've got time to pop it, to swallow it quickly, that can offset a seizure coming up. If people have no warning or they get very severe seizures, the epilepsy services use buccal midazolam. So that's midazolam that can be squirted into the inside of the cheek. In the community, you're unlikely to be using IV lorazepam, which has now replaced IV diazomols, which I think I was certainly brought up with. IM midazolam can also be given. Rectal diazepam has gone out. Again, Liz is going to talk more about this later, but we do have network epilepsy guidelines, which we're going to update and share. But the aim of seizures in the emergency setting is really to try to ensure the stability of the underlying seizure control and minimise emergencies and maximise people's ability to cope with fits if they do occur. And it's about appropriate medication at the correct dose, taken regularly, and also about lifestyle factors, because things like tiredness, hunger and stress can be an issue. And again, I don't want to steal Liz's thunder, but this is a great website, just www.epilepsy.org.uk. This is just a screen grab of some of the things, but if you scroll down, there are answers to every possible question you could possibly want about epilepsy, so that's highly recommended. Thank you very much.